This session particularly, we are going to have eminent speakers, and the panel discussion is about collaboration. I mean, how to leverage technology in collaboration. Say, basically, healthcare cannot function as a silo. We have found that, say, multiple agencies, let us government or private, or whether it is healthcare provider, health service provider, tech provider, so many people work together. And unless there is a collaborative effort, we have found that during COVID, a collaborative approach helped in reaching out to multiple patients in the crisis. So all these speakers will be speaking about how collaboration can be made effective leveraging technology. Next speaker will be Ms. Sunita Nadhamuni. Sunita Nadhamuni is the Global Head of Social Innovation at Dell Technologies. In this role, she oversees Dell Global Social Innovation Strategy that focuses on driving technology, enables social impact programs to advance health education and economic opportunities for undeserved. Sunita is also the founding member of Digital Life Care, a tech platform developed by Dell Technologies for Government of India national NCD programs. And we all know that NCDs is, government focuses on an NCD. Digital Life Care focuses on this platform. And also, in addition to her role as a global head of social innovation, she acts as the company's representative for the World Economic Forum's Edison Alliances. Welcome, Ms. Sunita. Hand it over to you.
Thank you. Thank you very much for this opportunity to speak here. So I wanted to, I've heard both the excellent speakers before me, and I'm using this opportunity to share the experience and perspective of a technology company who's come into public health and trying to leverage technology and collaboration from our perspective of using of a technology company coming in. I'm happy to share our experience working with Government of India. So we've been partners to the Ministry of Health and Family Welfare for the National NCD program. Now, I know there've been people talking about NCDs, but some of the key things that make it particularly, few points that I want to call out is that the characteristics of NCDs that make it particularly difficult to manage is that A, they're chronic. So you need to continue treatment, month after month, year after year. Only 10% of our rural hypertensive patients have their BP under control. And that makes them very vulnerable to any adverse effect. They're silent. So 50% of our breast cancer patients and 80% of cervical cases are caught in the third or fourth stage. And by the time their health outcomes are very, the 5-year survival rates are pretty low. And finally, not so intuitively, they disproportionately impact the poor. And this is because of a combination of both, their environmental conditions, social determinants in terms of awareness and, nutrition and their overall health-seeking behavior, as well as their low birth weight when they're born, and that which makes them more vulnerable. So for a combination of cases, for a combination of reasons, NCDs are particularly hard to manage as a public health initiative, right? Because of these three. And therefore, we feel that there is a role that technology can play, right? And of course, India, like many other countries, has done the epidemiological transition to go from communicable to non-communicable diseases. And this is the biggest disease burden today. So with this in context, the Government of India runs the National Program for Prevention and Control of Cancer, Diabetes, Cardiovascular Disease, and Stroke. It's called NPCDCS, right? And this has been running for a while, but in 2018, it was repackaged under the Ayushman Bharat Health and Wellness Centers to make it a population-based screening and management of NCDs. This is targeting the entire population over 30. This is probably one of the most ambitious and largest public health programs because it's targeting about 350 to 500 million people, right? For preventive screening of 5 diseases: hypertension, diabetes, oral, breast, and cervical cancers. So when the Prime Minister, when the Health Ministry came up with this program and it was going to be launched, they were very keen to see if a technology platform could be used. And that's how we came on board to partner with them. as a part of, this is all a part of Dell's ESG, environmental, social, and governance. So for Dell, our mission is basically, how do you use technology to drive human progress? And from that perspective, this is a really stellar example of how technology can actually play a role in one of the largest public health programs in one of the largest countries in the world. So the NCD program is delivered by the government public health system, right? And basically what this is a tiered system. It starts at the village level. You have ASHA workers, and ASHA workers are volunteer members of the community, and each one is there, one per village, so usually catering to about 1,000 people. And she has some training to take care of very basic triaging and very basic needs of the community, health needs. At the next level, you have the ANMs, the auxiliary nurse midwives, and the community health officers. And these are at the health and wellness centers. There were 250,000 of them. They cater to a population of 5,000. And then you have the primary health doctors at the primary health centers, and then the specialists, and then the district hospitals and the tertiary hospitals. This is the health system. Of course, it has about 150,000 health facilities across the country, and it has the administrative staff at all levels to run programs. So this entire machinery, which is, and of course, including the drug delivery, this entire machinery is responsible for delivering the programs for all the health programs. At the health and wellness centers, there are a package of 12 services, which cover everything from maternal to communicable to non-communicable diseases. So in this entire system, what are some of the weaknesses? As you can imagine, there are challenges with, insufficient infrastructure, with sufficient capability of the health staff. There is lack of visibility for the administrators who are running these programs, overall governance related issues, and standardization of care. And all of this is compounded by the fact that a large majority of the population are not proactively seeking out health. So the health seeking behavior is poor, which is particularly difficult for NCDs because, as I said, they are silent, right? So in this context, we started working with, 8 years ago, and I'll talk a little bit about our journey later, but basically we developed what we call internally at Dell, the Digital Life Care Suite of apps and a platform for India's National NCD program. And what are the 3 objectives of this software system? First and foremost, it's continuum of care for the individual. Basically, as a person goes through their journey from their home, getting, screened, getting diagnosed, getting treated, and then managed month after month, at any point they can fall through the cracks. And so continuum of care, making sure that the person is adhering to the treatment regime is the most important part of the whole healthcare program, right? So that is one of the biggest objectives, central objective of the software system that we've developed. The second thing is productivity and quality for care providers, because the ratios, just the numbers that I called out. Obviously, you have one primary health center doctor for a population of 25,000, and so there, we've done, spent a lot of time with the health workers and doctors, and they're all overburdened, right? So the idea is, how do you use the technology that we have today, that each of us use, you and I use, to really transform our lives? How can that be leveraged for these frontline workers and doctors? And finally, for the officials who are running these programs, how can you make data available to them in a way that they can make evidence-based decision making and really be able to respond more dynamically to the needs of the program across the country, because it's very, very diverse, of course. So the solution, the system consists, each of these bubbles is a solution. It's an application. It's a mobile app or a tablet app or a web app. And so it starts off, it's end-to-end for the all the participants in the health system. So it starts off with the community worker, the ASHA worker at the village level. There's a mobile app for her to do population enumeration and risk assessment, right? And this is a community-based assessment checklist that, this is again, completely Government of India guidelines, right? So the assessment will check on the propensity, what is the likelihood that the person may be at risk for NCDs because of their smoking or drinking or family history and all of that. And so all of that is captured. At the next level, the red circle is where the community health officer or the ANM uses the apps for doing basic NCD screening. And for patients who are already diagnosed, they use that for the follow-ups. Right? And for dispensing medicines, monthly medicines for hypertensive or diabetic patients, basic screening for oral, breast and cervical cancer, and hypertension, diabetes, all of that is done by the ANM, and we have apps for that. And then at the doctors, for the doctors and staff at the primary and secondary level, we have applications for them to be able to do simple, entry of the diagnosis, examination, management of the patients, right? All of this goes into the central cloud, where a health record with the unique health ID, we are working on ABDM compliance. We've already created the health IDs. And so a health record is created for every individual, irrespective of which worker, which health staff they've been to and where they've been to, right? It's one health record, one health ID for that individual that sits on the cloud. And then the administrators and the program officials, the last two, are the ones who the administrators are the ones who help run this, technology system for, at a district level, at a state level for all the users. And the program officials are the ones who are looking at dashboards to understand the performance and make decisions on how do you augment, what are the challenges, where do you need to focus on, right, as administrators. So this very comprehensive solution is what we worked with Government of India and all its partners. There's been a true collaboration from day one to design, develop, and deploy this system. And this has been primarily in partnership with Tata Trust as our program implementation partner. So basically, when I talk about, the two key features, one is there's a single longitudinal health record on the cloud with a single unique health ID. And more importantly, it's not a solution for one facility. There is a referral workflow that allows this continuum of care across community level, primary and secondary facilities, right? And this workflow will at any point give visibility for each of these care providers on where a patient is getting what kind of care, right? So currently the patient is at the ANM Health and Wellness Center being screened, or this patient is being diagnosed at the community health center or the district hospital. So that workflow and the visibility of the patient movement across facilities and across phases is what is enabled by the system, right? And more importantly, what it will say is that, now let's say the health worker, CHO, has screened somebody and referred them to the next level. The BP was high, sugar was high, you have to go to the PHC. But what might happen is, obviously because of the low health seeking behavior, because of a whole bunch of other challenges that the rural population faces, they may not go there. So the alerts that the health worker will get is say, this person was referred but never reached the next level. Or this person was screened but hasn't been, and though they were screened positive, they were not referred. Or this person has missed their follow-up. After 3 months, they missed their follow-up, right? All of these will help this overburdened staff at every level not just know what they've already completed, but what is yet to be done, which I think is more critical. It's one thing to know that, okay, I've screened, 500 of my population, but I have yet to screen 1,200 of my population. Or these are the 20 people who have not gone, they missed their follow-up, right? Loss to follow-up is something that's very, very important. And that's one of the things, these are the kinds of things that we make available in the application, right? So how did this start? Coincidentally, it started at Dell as just an innovation project, because Dell, we were very keen to say, we develop technology, we're a technology company, but we really need to see how we can solve end-to-end problems of the country. Right? How can we actually play a role in making a difference, making a societal impact? So we started this, the first pilot in 2013 and 14. We worked with Karuna Trust, Dr. Sudarshan, who's done remarkable work across the country. And this was completely developed with Dell volunteers, because this is not a business, revenue-making business. This is a complete CSR initiative for Dell. And the first version, we sat with health workers and completely did it with volunteers, developed the solution and piloted it with Karuna Trust. We started working with Andhra and Telangana, and with Tata Trust, really we've been working together for the last 6 years in working together to take, we develop the solution, they take it out to the field, they train, they handhold, they support, and then working with government, and then we keep enhancing it based on the need. So it's been a very tight, iterative relationship. In 2018, we started working with Government of India. It was launched by the Prime Minister. And as of 2019, we reached 5 states. During the pandemic, of course, there were dips, obviously, during, when COVID was its peak. But we still, by 2020, 45 million enrollments were done in the system. And as of 2021, 100 million enrollments. And today, as of Jan 31st, there were 135 million people enrolled in the system across 33 states, 593 districts, more than 94,000 people trained by Tata Trust and the state governments, a lot of users onboarded, and it's running across the country. So what are some of the takeaways from something like this, right? First of all, it is not a, obviously it's not a technology solution. Technology is an enabler. It is a Government of India program. And to add on a technology solution for a Government of India program requires a massive collaboration. I talked about Tata Trust and Dell, but all the other players who are a very important part of it, NHSRC were the ones who actually came up with the whole design and, working with us on the design of the system. We worked with AIMS, we worked with WHO India, NCDR, NICPR, all of these partners. Harvard is doing an optimization study. NIC is helping us deploy this massive technology. So it's truly a collaboration and a partnership, which is obviously challenging because you're trying to do a nation scale program, and it's just the scale itself is very difficult. But I think that this is the only way, and not to mention all the state governments who very proactively drive all their campaigns, right? So Tata Trust, like I said, has done this multi-tiered, training process. It's called Cascade Model of Training, and very actively involved across the country. So I want to close with, while I'm showing these screenshots, right? Some of the lessons that we have is that, first of all, this has to be co-created. You can't, sit and create it as a typical technology product. It just won't work. You have to work, our apps for the health workers, they are pictorial, they're offline, they're in 11 local languages. There's very little typing, because when we take it out to the field, they give us feedback. Oh, this is too slow, this doesn't work, this is too complicated. So it's a continuous refining, but you have to work with the stakeholders. And the insights that need to come. So one of the things we found is that there are heavy usage of the states. States use these dashboards very extensively when they need to, especially when they're running campaigns. So being very agile and attentive to the needs of the states as they're running campaigns and giving them the reports really helps them make their job better. So that's something that we've discovered. How do you manage, you can't support all 33 states as a small CSR team. With Tata Trust, we can't support all states all the time. So being able to figure out, who needs what kind of support when has been an important part of it. And then, of course, the integration, right? Everything that we create is open source. So, for instance, the health ID integration that we did with ABDM, we shared this with the Ministry of Tribal Affairs so that the sickle cell anemia team could use that without having to redo that on their own. So this integration and collaboration across within departments of government is something, again, that I think is very important. And we're really looking that, to ABDM and the integration. As that integration gets completed, we see that there will be much better interoperability and sharing of both, data and best practices across all these programs. Thank you.
Thank you, Ms. Sunita. And it's really amazing to see organizations like Dell has taken their CSR and ESG commitments very seriously, and put in process and technology in place for developing something like a NCD program pan-India. And as the previous speaker said, reaching out to the 1 billion population who has been left out of the proper structured health system in India. It's really amazing. Once again, I thank all the speakers for the amazing presentations and sharing their experience in various fields they have been working. As a collaborative approach, all these knowledge can be pooled and democratized and used for ABDM or any future programs for the public health. And I thank CAHO and Dr. Vijay Agarwal and Lalu for giving this opportunity.